me this opportunity and know what is. So the topic today is immunosuppression to reduce infection risk after transplantation. So it's a very tight topic where we are trying to just discuss certain drugs and their effect, how to combine them, and to get to a solution where you can, as sir said, balance both rejection and infection. So I'll just introduce the topic. I'll just outline some timelines, risk factors, immunosuppressants and infection correlation of certain immunosuppressants, what all strategies we have, what tools are there to monitor what we call nowadays the concept of net state of immunosuppression, and a very simple case for open discussion so that we understand what we should not be doing when we are so confused about with so many drugs around us. So starting with the introduction, kidney transplant rates have increased after the successful transplant of 1954. The most common thing which we encounter other than rejection is infection and malignancy. Second cause of death in patients with allograft dysfunction, and 70% of all KTRs, it at least has one episode of infection in every 3 years, and almost 45 per 100 patient years on follow-up also in the initial 3 years. And the most commonest cause of hospitalization is infection post-transplant. A very recent study, they took into two eras. One era was between 2011 and 12, and the second era was between 2017 and 18. And they found that even in both different eras also, infection was the most commonest cause of readmission to hospital after discharge. So what is the problem with infection when you are under immunosuppression? The problem is the therapy is causing the patient susceptible for microbial invasion. Because of impaired inflammatory response, this patient is prone to infection. And very difficult because most of the times because of immunosuppression, there is diminished symptoms. There are different radiological findings, different presentation. For example, if you take a very simple symptom of fever, is neither sensitive nor specific predictor of infection. In these patients, 40% of the infections, they really don't present as fever, especially the fungal infections. And 22% of the fevers are mostly non-infectious in origin. And we all understand that allograft rejection can also develop fever in transplant recipients. So with all this confusion about the presentation as well, it is very important that we titrate our immunosuppression in such a way that we don't land up with infection, and we do what we call as the balancing act. So we bring it in such a way that we don't increase the immunosuppression to cause infection, and neither we undersuppress to cause rejection. So with this, we go to the determinants of infection. So basically, the upper column, both causative organism and its virulence and etiology of infection is understood. But what is more important is to understand the concept of net state of immunosuppression and the current level of protection the patient has. The patient, whether he is vaccinated very well, and whether post-transplant did he get a proper infective prophylaxis for infections like CMV infections. So these factors are in combination is what really determines what will be the outcome or what will be the infectious complication. So risk of infection after transplant really changes over time, and no assays so far accurately could measure the risk for infection as we measure the risk of chance of rejection, at least with certain immunological markers. Now, just trying to correlate between certain drugs and possible infections they prone the patients to. So when you use an anti-thymocyte globulin, you can have activation of latent viruses. You can end up with, in a B cell suppression, you can end up with an encapsulated bacteria. When you undergo the patients for a plasmapheresis in patients of ABO incompatible or in patients where we have done sensitized transplant, chances of infections like line infections and encapsulated bacteria holds high in these cases. When you use a co-stimulatory blockade, you are increasing the chances of infection with Epstein-Barr virus and the possible presentation of PTLD in these patients. Steroids, we all know, can increase any set of infection, whether it's bacteria or virus, but most importantly, fungal infections increase post heavy dose of steroids after rejection, and wound healing is also delayed. Azathioprine, neutropenia, possibly papillovirus and other sort of similar skin infections. Mycophenolate mofetil, very notorious for all set of infections and mainly to activate viral infections, and also present lately for CMV, late CMV presentations. CNIs basically have some antiviral properties as far as cyclosporin is concerned, but still there's enhanced infections, both herpes virus and gingival infections, as well as intracellular pathogens. And mTOR inhibitors, they also can cause infections. It's sirolimus having more compared to everolimus, but they presented with certain idiosyncratic interstitial pneumonitis, which also had a problem before with those modification. So with these drugs, which we understand with certain application to immunosuppression causing infections, we are likely to pick up certain infections if you know what immunosuppressants they are undergoing. In this, none of the association are consistent, but still MMF with overall increase in infection, especially viral. And there are studies to prove anti-lymphocyte antibody and CMV reactivation. Combination of TAC MMF increasing the incidence of BKV, even steroid pulse increasing the incidence of BKV, and basiliximab basically reducing a risk of CMV, and everolimus basically when there's new regimen with low dose TAC, they have seen in many studies that it reduces the incidence of cytomegalovirus and BKV in post-transplant state. So when you look at the etiologies of infection, we are very aware that in the early stage we are dealing with surgical related infections, nosocomial infections, as well as donor related infections. And later we are more related with reactivation, opportunistic, as well as community acquired infections. And when we know our standard timeline of infections, where we discuss about less than 1 month being bacteria acquired from nosocomial from the hospital, mostly resistant species, UTIs, wound infections, to the first 6 months where viral infections also play a major role, in spite of people who are without prophylaxis and with prophylaxis as well, where HCV infections, streptococcal infection, mycobacterial infections are on the, and after 6 months, all sort of community acquired pneumonia, infections related to fungal as well as viral infections like CMV and BKV take up. But if you look at the different phases of transplant, how we proceed with immunosuppression, we are very aware that in the phase 1, which is less than 4 weeks, that's a post-operative state, we are mostly looking at nosocomial and lines related with viral infection, fungal infections, less in this phase of time with possible prophylaxis. But when we look at the intense immunosuppression phase, which is probably up to 6 months, your chances of other set of infections go on to the rise. But more importantly, what we have to be mainly careful about is the phase 3, where this is going to be the long-term immunosuppression. So whether we could achieve a stable low-dose immunosuppression in that patient, or whether there was multiple rejections and poor graft function leading to more infections like CMV, BKV, EBV, or any sort of fungal infections like aspergillosis. And on the whole, if the patients are repeated infections leading to malignancy or any other set of viral infections leading to graft loss. So this third phase is mainly which we really need to act on at point of time, which we can do at this point of time, and as well as before phase 1 at the induction level. So what are the immunosuppressive strategies we have got? So when we talk about net state of immunodeficiency, here what we mean is basically that it's not only the immunosuppressive in the regimen which is important, also the individual predisposing factors in particular patient. So every patient is different in transplant. So what that patient has got as a predisposing factor to infection will be amounted to by immunosuppression, whatever we are going to use in that patient. So that will define the net state of immune deficiency in that patient. So whenever there is rejection or immunological risk stratification, whenever there's a rejection, we look into the immunological risk stratification. We have something to look upon whether this patient was stratified as mild risk, or whether this patient was moderate risk or high risk, depending on various parameters. But when it comes to infection, there is no established approach to identify which category this patient will be and how we can decrease the immunosuppression to achieve that sort of immunosuppression which will not lead this patient to get any serious infection. So therefore, we need an integrated risk stratification approach where we must identify the risk factors in that individual patient. For example, some of the most studied risk factors are extremes of recipient age, female gender, disease donor transplantation, older donor age, CMV positive donor, higher HLA matches, delayed graft functions, or patients where they have primary diseases like SLE or diabetes mellitus pre-transplant, and patients who have got catheters and grafts in place. So these are the patients who are more prone for infection. This predisposing factors with the net immunosuppression which we are going to give will define the total net immunodeficiency in this patient. There was a study in 2015 where they really tried to see the risk stratification for both rejection and infection, and they found that the similar incidences were present up to the first year after transplant, and at around 139 days from the day of transplant, both the risk factors had intersected with each other. So this just implies the point that there's so much connection between the immunosuppression timeline. When we try to decrease it for infection, we land up with rejection at the same time. And that's a course which happens commonly in a transplant patient. So what are the ways of prevention, finally, which is more important for us in today's topic? So we have got pre-transplant measures, we have got peri-transplant measures, and we have got post-transplant measures. In the previous talks which happened on the same platform, the other parts were looked into, like screening of the donor to choose an appropriate donor which does not have any latent infection, or the screening of all the blood tests required to rule out the possibility of infection in the donor is very, very important. Screening and treatment of the recipient. If the recipient has any particular infection, has to be screened earlier and to be treated, and certain protocols to be followed with respect to the individual infection. And prophylaxis if required, suppose in a patient of tuberculosis, INH prophylaxis if required should be considered. But the most important is the third phase of vaccination, which we always tend to, we follow the protocol, but in case missed, will be deleterious for the patient post-transplant. So all the live vaccines has to be completed pre-transplant, and very major emphasis has to be given to this for in case of any transplant, pre-transplant workup. Peri-transplant measures, antibiotic surgical prophylaxis, technical measures to be taken into account, and in post-transplant measures, dynamic surveillance, post-transplant prophylaxis for infection, as discussed in the previous talks, are important. Today's topic is mainly on immunosuppression, so I'll be dealing with only two parts of it, that is induction regimen and immunosuppressive regimens. When you come to induction therapy, maintenance therapy and anti-rejection therapy, the first phase, that is induction therapy. The most commonly used drugs in our clinical practice are two, basiliximab and ATG. I have not touched upon alemtuzumab in this presentation. So when you look at basiliximab, as per the low immunological risk patients, we prefer to use basiliximab, low to moderate. And I think COVID infection taught us a lot. During this time, we had a lot of patients being induced with basiliximab, and we had gained confidence with the molecule. As far as active history of viral infections in patients who are elderly recipient donors, or patients who have a disease donor with moderate high infection risk. So as George sir said before, you have to choose the right induction in the right patient. So with such history of infection in the past, patient who has lost a graft to an infection in the past, or patient has got elderly recipient donor or disease donor, basiliximab can be considered as a primary induction agent. For patients who have got high immunological risk with high number of HLA mismatch but higher risk for infection, you can go up to low dose of ATG, or you can go for high ATG for high immunological risk with minimal infection risk profile. So the choice of induction agent and the amount of induction agent in the patient has to be decided depending on what the primary characteristic of each recipient individually. But when you look at the maintenance therapies, what are the options we have got? We have got CNIs, MMF, mTOS, and steroids, which commonly we use. When we look at each of the ones of immunosuppressive agents, if you look at CNI, it almost causes all sort of infections. Viral infections are more with tacrolimus compared to cyclosporin. BKV most common with TAC, CMV infections. So mostly all viral and bacterial infections are prone with CNI. But an added problem with CNI is certain toxicities of these drugs also make the patient prone for infection. So diabetes, post-transplant diabetic PTDM can cause an increased risk of infection. And also patient with MMF, basically if you look at the profile of MMF, almost increase in almost every infection possible, both bacterial, viral more common. And when we go to mTOR inhibitors, more of bacterial, less, they are more little protective towards viral infections. And when you look at steroids, most commonly common for fungal infections as well as bacterial infections. So with this profile of the immunosuppressants with the possible infections in them, it's very important to titrate the dose of these drugs as we move on from third to 6 month and from post 6 months to the follow-up and post 1 year. And very important to be monitoring their levels and giving up medications as per the need and following up with the graft functions at regular intervals. So how we can modify these drugs? So basically, immunosuppression reduction is based on clinical oversuppression. So if you have trough levels of both TAC or CSA or MMF AUC levels, if you are seeing and they are on the higher side, we can adjust the drug dose. Same way, immunosuppression reduction or elimination is possible in form of in pediatric transplants. Mostly we see steroid reduction and withdrawal. You can avoid steroid in very well matched patients. CNI switching is very easy to reduce the dose of CNI or even to switch to or add with a low dose of mTOR inhibitors with the, as a combination to avoid infections later, and alternative regimens. So based on this, there was a study which was recently published, which was Transform study, which is the largest randomized control trial till date. It is about de novo kidney transplant. More than 2,000 patients across 146 countries were involved in this transplant study, where the pre-transplant induction was either bisiliximab or ETG as per the choice of the patient with steroids. In less than 24 hours, they were randomized into two groups. The first group was about low dose everolimus with everolimus plus low dose CNI plus steroids, and the second group was MMF with CNI plus steroids. And what they were doing in these three groups was, in the first case, the low dose level of tacrolimus or cyclosporin. For example, if you take TAC level, average first category was 4 to 7 nanogram per ml is what they were maintaining. They went up to 2 to 5, and even certain patients, they went as low as 2 to 4. So they were trying to use the minimal TAC dose. The main intention here was to see whether the patient had equal efficacy to MMF in terms of biopsy proven acute rejections, and what is the evidence of these drugs in the effect of infections. This study went on for 24 months. At the end of the study, in relation to infection, it was found that there was significant reduction in the risk of infections in comparing the low dose CNI with the mycophenolate group. So everolimus plus low dose CNI showed marked difference in the viral infections, specifically the CMV infection as well as the BKV infection. So there was a total reduction of 13% in the overall infection, 41% in viral infections in totality, of which 73% reduction, which is very huge as far as CMV infection is concerned, and 46% reduction in BKV infection. So as well as this study also showed the biopsy proven acute rejection between the two groups were almost equal, and the efficacy of the drug was fairly same. This study has been extended for another 3 years, so probably by 2025 we'll be able to get the post follow-up of these patients on how they did after in the long follow-up of these groups. One more part of maintenance therapy when we talk about is glucocorticoids, steroids, which we mentioned before, that we can have a steroid reduction or a steroid withdrawal or an avoidance protocol. Most basically to compensate, and there are a lot of studies both in India as well as globally where they have been able to completely avoid steroids and maintain good graft function, mainly in pediatric patients. When you come to the last part is about the anti-rejection therapy. So when you use an anti-rejection therapy, they can be critically predisposed to infection. So basically, there is an altered pro-inflammatory and anti-inflammatory milieu, and the drugs most commonly used are ATG, high-dose steroids, and plasmapheresis. When it comes to ATG, the chances of getting graft infection, graft abscess are very high. The rate of CMV and BKV viremia increases, and there is increased incidence of invasive fungal infection post-rejection treatment. Same with steroids also, there is increased incidence of BKV infection. So the most appropriate prophylaxis regimen should be adopted. So the most important point here is that whenever we are giving an anti-rejection therapy, we should be definitely following it up with an appropriate prophylaxis regimen for these patients. and the prophylaxis regimen should be continued and followed up in the following OPDs. So it is very important that whenever you're using an anti-rejection therapy, immunoprophylaxis, infective prophylaxis should be given. Now, whether the question is like, as we discussed in the initial slide, it's so easy in immunological, not so easy, sorry, but something is there to find out the post immunological surveillance for seeing any immunological chance of rejection is there. So something is there to identify it, but for infection, it's very difficult to get to a tool like 1, 2, 3, 4, and we find out that this patient is prone for infection or which drug is the cause for the same. So in this case, what are the possible things available for us at the moment is basically the most important, and what we do regularly is the drug levels. So measurement of immunosuppressive drug levels is used to avoid drug toxicities, graft rejection, and infection. Correlations exist between rates of, like, for example, herpes virus infections and MMF levels. So if the AUC under the curve is balanced, most of the viral infection resurgence is less when it compares to MMF. So this is just an example, but drug levels is one way of monitoring our immunosuppression to reduce infection. There is something called as immune function assays. We can look into the WBC count, differentials, T, lymphocyte subsets to see how far it has been immunosuppressed. So whether we need to give the second dose or we can try for a reduction of dose. Reduce CD4, CD8 lymphocyte count, risk opportunistic infection and CME post-transplant. That part can be identified. Low total lymphocyte count after a CMV treatment predicts the chances of increased risk of relapse. Patients who have got hypogammaglobulinemia or reduced serum complement C3 levels or mannose binding lectin deficiencies are associated with respective increase in infectious risks. There is one thing which comes along with this is dysbiosis. Nowadays, it's very common to understand dysbiosis in CKD. The same thing holds true for dysbiosis in post-transplant infection as well. The microbiome has emerged as an important determinant of immune function. Dysbiosis is common because of immunosuppression, antibiotics, and post-surgical phases of the patient's stay in hospital. The reduced gastrointestinal butyrate-producing bacteria in kidney recipients are associated with increased viral respiratory infections. So it's certain studies they have added probiotics to patients who are infected, like lower respiratory tract infections as well as PCP pneumonias, for a better response in these patients. Still, a lot of studies are required to detect it in transplant setup, but still dysbiosis plays an important role in preventing infection. There are a lot of novel ways of finding out the problem to titrate whether this patient will have a chance of infection with that level of immunosuppression. So one of the method is the torque virus load. Since most postgraduates are listening to this talk, I thought this will be an important slide for them even in exam. So torque virus load is a non-pathogenic single-stranded DNA virus which mirrors the net state of immunosuppression. So if the viral load is high, we know that the immunosuppression load is high, so we can reduce the dose of immunosuppression. So it's a non-pathogenic virus, so it can be done with blood samples. Quantiferon monitor, which is interferon gamma levels, where they are trying to see the IGF levels. Interferon gamma levels are on the lower side, more prone for infection. Immuno is the amount of ATP that is produced by the CD4 T cells. So this is a very good test which has been used only in trials at the moment, but will come soon probably, where ATP, if it is on the lower side inside a cell, the chance of infection is very high. And when you have higher level of ATPs in the CD4 T cells, it somewhere reflects that possibility of rejection is high. So they are looking into that part in Immuno. And post-transplant TVS level, that is virus-specific T cell levels, also indicate to us that we need to reduce the immunosuppression so that we can titrate the possible chance of getting an infection. With that, I come to the take-home messages. So stratify immunological risk and use induction agent wisely. Rejection and infection are interlocked with each other, and hence immune monitoring and drug levels of immunosuppressants help in maintaining balance. Drug level monitoring is key. Monitoring for infections like viruria and viremia also helps to monitor adequacy of immunosuppression. Before leaving this for discussion, I just want to put a very simple case for open for discussion, because most of the other significant patients where there are a lot of problems, second transplant, we tend to use more drugs and comparative. Where what not to use? For that context, a simple case of 23-year-old male patient who is a viewer induced CKD at age of 20 years, was on Maintenance dialysis 3 per week since 1 year. Mother as a donor, is the only son she has got. First, only child she has got. First transplant, non-sensitized patient. CDC flow both negative, DSC negative both class 1 and 2. What will be the choice of induction agent, whether you'll give or not to give, and what will be the immunosuppression protocol at start, at 3 months and follow up.